Good afternoon in New York and all over Turtle Island or North America. Good morning, good afternoon. The United States and Canada, that is. Good evening in Europe and Africa, and welcome whatever time of day or night it is for you who are joining us from all corners of the world. I'm Yael Danieli, founder and executive director of the International Center for MultiGenerational Legacies of Trauma, ICMGLT for short. Thank you for joining our webinar, Multigenerational Trauma and Survivance Among Indigenous People in Turtle Island. We've been waiting with great anticipation for this webinar for a long time. This International Center for Multigenerational Legacy of Trauma webinar is held ahead of the International Day of the World's Indigenous Peoples, observed annually on August 9. Anishinaabe and Tolowa Chetco scholars will present their research assessing the multi-generational legacies of Indian residential boarding schools in Canada and in the United States. Despite the unique context of settler colonialism that continues to harm Indigenous people in Turtle Island, their research has also identified individual and collective protective factors that are culture-based and promote wellness. Reflecting the collective strength and resilience of Indigenous nations, the concept of health survivance will be also introduced and discussed. For those of you who have been with us all along, you remember the prior webinars on the residential schools, those horrible, horrible stains on human conscience in history. You will see how uniquely different this one is. But for those who have just joined us for the first time, I recommend that you go on the website and view all of the webinars on residential schools. So you will get so many differing dimensions of this horrendous issue. Your moderator, I am a clinical psychologist, traumatologist, victimologist, and psychohistorian. I have devoted much of my career to studying, treating, and writing about and preventing lifelong and multi-generational impacts of massive trauma, to ensuring victims' rights across the world, to the rights of future generations, and to reparative justice. For today's webinar, the most relevant one is that my concept of psychohistory views history not only as a series of dates and events, but as we live it, as it is lived by us today, every day, shaping and guiding the meanings of our lives. Today's first speaker, we have two today. Today's first speaker, Amy Bombay, is an associate professor in the Department of Psychiatry and the School of Nursing at Dalhousie University. Amy is Anishinaabe, Rainy River First Nations, and completed her MSc and PhD in Psychology and Neuroscience. Her primary areas of inquiry have focused on assessing the association between historical trauma, contemporary stressor exposure, and cultural identity in predicting mental health outcomes among Indigenous people. Our second speaker is Rachel E. Wilbur, a descendant Tolowa Chetco. Rachel is an assistant research professor with the Institute for Research and Education to Advance Community Health in the Washington State University Elson Floyd College of Medicine. Her research focus is on the role of cultural engagement and revitalization in promoting well-being for American Indian and Alaskan Native communities, and she's particularly invested in community and strengths-based research. We have an hour and a half for the webinar. Each of our panelists will speak for about 30 minutes. Following an interchange among the three of us, I will open the floor to questions and brief comments from the virtual audience. We will then conclude with final words, or last words for today, not forever. Please use the chat function and the question and answer, the question function, and we will do our best to respond to as many as we can. Feel free to direct your question to a particular panelist or to all three of us. I now have the pleasure, the great pleasure, to offer the screen to our first speaker, Amy Bombay. Amy, the screen or floor, it's all yours. Go ahead.
Okay. Hi, everybody. Can you see my screen okay?
Yes, we see it.
Okay. I'm just having a bit of a problem on my end. Just one sec. Okay. Okay, so thank you so much, Dr. Daniele, for the invitation. I'm really happy to be here. So I guess I'll just jump right in. I'm Amy, and this is a picture of my ancestors from Rainy River First Nations in Ontario, in Canada. And so I'm going to be talking today about my research focused in Canada, and then I'll be passing it to Rachel, who will focus on present on her research from the US. And just very quickly, we put together just 3 learning objectives that just to give you an idea of what we'll be talking about today. The first one is to understand the unique experiences of multi-generational trauma as a result of colonialism experienced by Indigenous peoples in Turtle Island. And most of this is going to be focused on residential schools and boarding schools, although colonialism is much more broad than that. We will then also look to understand the root causes of contemporary and social health issues within some Indigenous families and communities. And also we'll end by recognizing the strengths of Indigenous peoples who have survived by actively engaging in colonial resistance and revival of traditional cultures across generations. And just to send some love to everybody, and we were talking about some difficult issues here, and so please do take care and feel free to take a step back and take care of yourself if need be. So just to give you a little bit of background context in Canada, we have 3 Indigenous groups, which is First Nations, which is the largest group, making up about 60% of Indigenous peoples. Which itself is very diverse, with over 50 different nations and 600 different communities. We also have Métis and Inuit. Most of the research I'll be talking about today is focused on First Nations. And if you have any questions about that afterwards, I'm happy to answer. So I don't have time to really give a thorough overview of colonialism, but just to give you some brief points from Canada, Canada was became a country in 1867, but centuries before that was first contact, and leading up to Canada becoming a country, as settlers began to look to stay and began to look to taking the resources from the lands and settle. Indigenous people became what was called in Canada as the Indian problem. And that was followed by various policies explicitly aimed at assimilation, including various broken treaties, stolen land, forced relocations, and many more. There were laws that prohibited cultural practices and ceremonies. And what I'll be talking about today were the laws and policies that really targeted the assimilation of children, which in Canada we refer to as the Indian residential school system. And I'll also be talking about the 60s scoop in Canada, which has to do with the disparities that continued from the residential school system into the child welfare system. So it was really in 1996 in Canada that I think Indigenous issues in terms of the huge health and social gaps relative to the non-Indigenous population and some of the negative effects of colonialism really only became known in the Canadian consciousness after the Royal Commission on Aboriginal Peoples released its final report in 1996. And this emphasized the intergenerational and long-term effects of residential schools and other aspects of colonialism. It emphasized the importance of culture-based healing practices and concluded that tinkering with existing programs and services would not be enough to foster substantial improvements in the health of Indigenous peoples, and called for new and innovative approaches. Unfortunately, many of our CAP's recommendations were not implemented, and about 20 years later in Canada, we had the Truth and Reconciliation Commission of Canada, which also reported on the continued and in some cases growing disparities relative to the non-Indigenous population, and many of the same calls that echoing from our CAP's report. It was also reported in the TRC final report in 2015 that it had become clear over the course of the Commission's work that most adults in Canada had been taught little or nothing about residential schools, and that the poverty and social dysfunction of Aboriginal communities were taught without any historical context to help students understand how or why these conditions came about. This omission has left most Canadians with the view that Aboriginal people were and are to blame for the situations in which they find themselves, as though there were no external causes. Aboriginal peoples have therefore been characterized as a social and economic problem that must be solved. And so, and I think that kind of continued lack of awareness around colonialism, both the history and the long-term effects, continues, although it has, there's a lot of hope moving forward because it has improved in Canada. But I think some of it stems from some myths that maybe have been perpetuated, and such as one is in Canada that residential schools were meant to help Indigenous people, and people don't really acknowledge that actually the explicit aim was assimilation, and that throughout history from government documents we know that they knowingly exposed children to neglect and abuse. This is just an example in Canada from government reports from the 1900s where a doctor who was a doctor for the government visited 35 residential schools and reported malnutrition, overcrowding, poor ventilation, unsanitary conditions that contributed to high instances of diseases. Almost all of the schools had tuberculosis, and this doctor called for equitable access to treatment, noting that the budget for tuberculosis for First Nations across Canada was much less than what was provided to the less populated city of Ottawa. And he concluded that medical science at the time knows just what to do, and implored for improved ventilation and to stop combining sick and healthy children. a lot of his calls at the time were not addressed. And this is some statistics from residential schools of the death rates of students. In the dark bar is those of the general population for children, and the bar in the dark gray is the death rates from different types of residential schools. And you see up until the 1950s, when things got a little bit better in terms of residential schools conditions, these huge disparities in death rates, and now we've learned over the past several years about more and more unmarked graves of former residential school students. And so it was really in the 1990s when we started hearing more stories from residential school survivors about the widespread abuse and neglect, the cultural denial and shaming that happened in residential schools, and just the trauma of being separated from their families, cultural communities, and cultures. And in Canada, we also had, in addition to residential schools, a lot of Indigenous students who did not go to residential schools went to day schools, and a lot of those children really faced a lot of the same exposures to childhood adversities, except that they didn't spend the night there. And then more recent research has just confirmed these early, more qualitative research from the 90s. This is a national survey of First Nations adults living on reserve, reporting their perceptions about childhood adversities that at residential school that negatively affected them. So this is just those that perceived a negative effect, and so we would guess that the actual exposure proportion would be higher. But we see that even those who perceive negative effects from these experiences, just looking at emotional and verbal abuse, we see that 80% of those who spent 3 or more years at residential schools perceived that had long-lasting effects on them. And we also interestingly looked at compared those who attended for only 0 to 2 years compared to those 3 or more years, and not unexpectedly, those who spent more time at residential schools perceived more negative long-term effects. And so based on research in other populations, we would expect that residential school survivors, because of the different types of adversities they experience, we would expect them to be at risk for various negative health and social outcomes. This is the Adverse Childhood Experience Study in the US, kind of the landmark study that really emphasized the harms of various types of childhood adversities, and also the cumulative effect of exposure to multiple childhood adversities, which research has since shown is associated with most negative health and social outcomes that you could measure in research. And so indeed, when we look at residential school survivors, again, this is First Nations adults living on reserve from across Canada. And we found that residential school survivors, a greater proportion reported moderate or high psychological distress compared to those within the red, who were those whose families were not affected by residential schools. And then the gray bar here is the non-Indigenous population at the time. So even those not affected by residential schools are still at greater risk for distress, and that's going to be associated with the collective effects of these of residential schools and communities and other aspects of colonialism. And I'll talk about some of the collective effects a bit later. Just to give you another example, this is again from the same survey, looking at different types of substance use, and we see that those with at least one grandparent who attended residential school, those with at least one parent who attended residential school, and survivors were at a greater risk for substance use compared to those whose families were not affected. So I could give you a lot of examples. We found those same types of associations with parental and grandparent attendance in relation to different types of mental health outcomes and certain physical health outcomes as well. But the next question we really wanted to answer is, what are the pathways involved in these increased risks? And this is one of our first early studies looking at this. And because of a lot of the qualitative early research revealed that, I guess most of it kind of focused on the harms that residential schools did in terms of affecting survivors, their ability to provide their children with adequate environments to promote health and well-being. And indeed, we found that those with a parent who went to residential school were more likely to report a higher number of exposure to different types of childhood adversities, including things like poverty and neglect, which is, associated with these communities where basically the whole communities were facing poverty at this time. So those are things that were outside of the parents' control. And then in turn, those increased risk for childhood adversities in the children of survivors put them at risk for exposure to continued stress and trauma throughout their lifetime. So we looked at the number of adult traumas they faced and their levels of perceived discrimination in the past year. And in both cases, those was a parent who attended reported higher levels. And in turn, when we conducted kind of fancy statistical analyses that were looking at what we call mediating pathways, we found that all three of these childhood and adult stress and traumas contributed uniquely to their higher risk for depressive symptoms. In addition to greater exposure to the number of stress and trauma, we also found that children of survivors were more likely to be more affected when exposed to these stressors. In the same study, we found, and this is just the example looking at adverse childhood experiences, we found that those with a parent who attended, when they were faced with high levels of childhood adversities, they faced these really high levels of depressive symptoms, even higher compared to those who had no parents who attended, and when they faced adverse. So you see this increased, kind of vulnerability to these exposures. And we found the same patterns in relation to adult traumas and perceived discrimination as well. And just to give an example, this is on the right is a graph from a study that looked at second-generation Holocaust survivors, also looking at depressive symptoms. And the stress in this situation was that they were that some of them were diagnosed with cancer, and they were compared to healthy controls. And so what they found was a similar pattern where those who faced the stress experience, those with that Holocaust family background, were more susceptible to the negative effects of that stress. So the similar kind of patterns. Another big question that came up in our work was whether or not the effects of residential schools might accumulate across generations, because residential schools happened over centuries. And so a lot of First Nations families were affected at multiple generations. So with this survey, they ask about parent and grandparent attendance and their own. So in this, we excluded those with who personally attended and just looked at those who were either not affected or who were either had a parent or a grandparent who attended, so one previous generation. And we compared those to a parent who had a parent and a grandparent, so two previous generations. And what we find was that, we see this kind of cumulative effect where those with the two previous generations were at the highest risk, followed by those with one previous generation and those not affected with the lowest levels of distress. And we also looked at the same pattern in relation to suicidal thoughts and attempted suicide. And again, we see the same pattern. We've looked at it in relation to some other outcomes, and we generally find that we only see this kind of cumulative effect in relation to mental health outcomes, but we haven't looked extensively, so that's something we still want to look at further. So in Canada, sorry about this very busy graph, I'm just going to summarize it, but it's basically, it's showing you the proportion of status First Nations children who were attending residential schools over the years. And so it was in 1950s that some people who were really against the harms of residential schools finally convinced government to close residential schools. But because it was such an extensive system, this took many years. And so it took over 50 years, for them to close completely. And the last school didn't actually close until 1996. But at the same, and so just to give an example of the proportion of the population today who's been affected, this is showing First Nations children, youth, and adults living in First Nations communities at different time points. And we see across these different times that about 75% of the population of First Nations living on reserves either attended residential school themselves or had a parent or grandparent who attended. So I think also in Canada, there's a myth that, oh, it's only a small proportion that was affected and it was a long time ago, but this is still today. This is just some examples in other groups showing these similar intergenerational effects, just to emphasize, and I think a lot this audience in particular knows that we see similar effects in other populations. So at the same time, while residential schools were closing, there was another policy change that allowed child welfare workers to start entering First Nations communities, which didn't happen before that because children were just sent to residential schools. But this is showing the proportion of status First Nations children who were taken into the government by the child welfare system. And we can see this increased from the 1950s up until the height in the 1970s at about 7%, and then started decreasing again into the 80s. And if there's just a couple of comparison bars there of the orange bars that showed in comparison about 1% of the non-Indigenous population was being removed into the child welfare system. So in Canada, this is what has since become known as the 60s scoop. This, even at the time in social, I think another thing is, well, they didn't know it was so harmful back then, but actually it was accepted at the time in social work that child apprehension should be the very last resort because of its own harms, and that Indigenous children were particularly vulnerable to the harms of removal. This is Patrick Johnson, who had a very influential report in the 1980s, where he kind of first exposed the huge disparities in the child welfare system. It was in his 1983 report where he described how provincial child welfare workers in BC used the term 60 scoop to refer to this increasing apprehension, and that one social worker admitted that they would, quote, quite literally scoop children from reserves on the slightest pretext. And so that's where the term 60 scoop came. And in the same report, Johnson quotes a government report called the Hawthorne Report in 1966. That was quoted as saying the child welfare situation for Native people, with some exceptions, could still be described as varying from unsatisfactory to appalling. And that was the quote, unsatisfactory to appalling, back in 1966 as well. And then also to emphasize, this is a report from 1994 that was actually written for RCAP's 1996 final report. And again, even at this time, it was being emphasized that the risk of damage by separation trauma by removing Indigenous children from their parents is more serious and harmful than most parental acts of omission or commission. So that in and of itself is so traumatic. And if children are being removed from various situations of abuse or neglect, resources should be diverted to programs for treatment and prevention of abuse instead of the significant amount of money they're spending removing them. And of course, if children are being, they pointed out, if children are being removed inappropriately, this must change. So that was back in 1994, and supporting, and not only is that separation in itself such a huge trauma. This is data that we recently collected with a 60 Scoop survivor group, where we asked about different types of childhood adversities, and specifically asked if they experienced them while they were adopted in their adoptive home, in foster care, or in a group home. And we see, while these children are being taken out for abusive situations, the places that they're being put into, they're also being abused. And so they're facing the same abuse in addition to the parental trauma. So these are just a couple of examples. This is the proportion who experienced physical abuse while either at an adoptive home, at foster care, and a group home. And we looked at it across years. And so it did get better over the years for most outcomes. But even in 1991 or later, there was still about 40% who were physically abused in adoption, 87% who were abused in foster care, and about 63 who were abused in a group home. And this is just another example where we look at the proportion who experienced racism from a caregiver in these different, while adopted or in foster care in a group home, and again, these really high levels. And we found the same thing for a number of different childhood adversities. So this is just a graph to show you. So the red and black line is the proportion of the on-reserve child population. And it just shows how it grows. It starts growing in the 1990s, and at the same time, where it says Directive 20-1, that was a policy changed. So actually, sorry, I'm going to back up. So we see this peak of the 60 Scoop at the late 1970s, and then you see the rates go down. And that was because at that time they started, because of the activism of First Nations communities fighting to keep their children in their communities, more and more communities were able to take over their own child welfare services, and we saw these rates go down. But then in 1990-ish was when this new policy change went in that affected the funding levels, and all of a sudden we see these rates go sky high, even higher than the 60 Scoop, and now in Canada we've referred that to as the Millennium Scoop. And today this is the census data from 2016, but I know it hasn't changed much recently, but in Canada 7.7% of all children under the age of 14 who are Indigenous are in foster care, and that's 7.7% of all children are Indigenous, yet 50% of children in foster care are Indigenous. So that's such a huge disparity. We're seeing about half of children in child welfare today. And so this is just a quote from Lawrence Kermeyer, and it's been noted throughout the years where many have argued that the child welfare system, through its large-scale removal of Aboriginal children from their families, culture, and communities, be considered a continuation of the policies of the forced assimilation of the residential school system. And so we wanted to look at this. A lot of kind of qualitative research had looked at that and supported that notion, and we wanted to try to look at that quantitatively. And what we did find that those who had a parent who went to residential school were more likely to themselves have been taken by the child welfare system and to have been apprehended. And when we looked at what was kind of one of the pathways that accounted for this relationship, we found that those with a parent who went to residential school were exposed to higher exposure to various types of adversities, which put them at risk for being taken by child welfare. We also, in a different study, wanted to look at the mental health effects of one's personal history of being taken by the child welfare system. And not unexpectedly, considering the abuse that many children face while in the system, we see higher levels of depressive symptoms. And in a national sample, we found similar associations with psychological distress. So this is not our work. This is a graph showing the effects of familial relocation experiences and how that's associated with across 3 generations outcomes in youth. So they showed how that family relocation experience was associated with grandparent alcohol problems, which was then associated in the subsequent generation, depressive symptoms and alcohol and drug problems, and their warmth and support in relation to their children, which in turn was linked with depressive symptoms and youth delinquency. This is a study by Walls and Whitpeck. And just to emphasize, a lot of my research hasn't focused on this, but just to emphasize, at the same time that residential schools was happening, as child welfare was happening, all these other aspects of colonialism were occurring at the same time. So just to emphasize that this is happening alongside all of these other harmful aspects of colonialism. So this is we're actually starting to look at this in research, but we haven't yet. But another pathway that is potentially involved in the transmission of trauma across generations, various biological pathways. And different Indigenous researchers like Dr. Karina Walters, Dr. Yellowhorse Braveheart have written about that these biological pathways are certainly involved, even if we haven't looked at it in Indigenous populations very much yet. We have seen this in relation to the intergenerational effects of the Holocaust in the children of Holocaust survivors. They've shown alterations in your stress response, cortisol levels, and they've even shown epigenetic differences in the children in very small samples. But so that's something that our team is starting to move towards. But first, before we do that, we're engaging in communities in education around biological health and development before we move forward with that work. So another pathway that our research has looked at is communication within the family. And I don't have time today to talk about all of the different themes that came up in our qualitative study that looked at this, but I'll just highlight one of the themes was the harms of cultural disruption. And one person from the study said, I have no prior knowledge of being a father. I should have been taught how to raise my children traditionally, but my father lost that in residential school, and therefore so have I. Another shared, the loss of our culture and language was by far the largest impact. English was the first language in our house growing up, and I was not even aware that I was Aboriginal until 10 years old or so. At the same time, on the flip side, we heard a lot of stories of cultural pride from people, both those whose families were not affected by residential schools, and some even more in those whose families were affected. This person shared, I've made a concerted effort with my own children to reintroduce them to our language and culture and to instill pride in their Aboriginal roots. I just wanted to briefly touch on this study that we did that was commissioned by the Aboriginal Healing Foundation in Canada, and they wanted us to try to look at what are the collective effects. So a lot of research focuses on effects at the individual level, but we wanted to look at how it affects whole communities when a large proportion of a given community is undergoing this same trauma. And we did this just by talking to health service workers who have worked with communities affected by residential schools. And again, we identified a number of themes, but I'll just mention 2 of them. One of them is in communities, the collective effects and the collective silence that was observed in communities. Some shared it had not been safe for people to make those kinds of disclosures in their own families and communities for fear of being ostracized and being told they are lying and to stop making trouble. We also heard collective effects in relation to community relationships and what's termed lateral violence, when within the community, people are kind of turning against each other. One person shared, it's part of the systematic way that people in power used to teach us in residential school. They were abusers. They had to make sure we also knew how to be abusers, not only of other people, but to have hatred against ourselves. Abuse begat more abuse, and bullying was only one form of it. And today we see it in some First Nations schools. So coming back, and I'm just wrapping up here, and I'll hand it to Rachel soon. But again, in our research looking at the communication across generations, we heard these stories of resilience. This person shared, I think my mom showed me more than she told me. She's very traditional and has practiced our culture in front of me when she could. My mother remained a traditional woman and has maintained her language. My mother has always been a very proud Native woman. And this person shared, I was ashamed growing up, but I've since reclaimed my identity. And now that I'm on my own, I have more pride and I'm learning to love my identity. I gave my son a traditional Ojibwe name and I vowed to raise him to be proud of who he is. And again, this is data from First Nations living on reserve from across Canada, looking at adults, youth, and children. And we looked at it as a function of whether they attended residential school or had a parent and grandparent who attended. And we see in adults, youth, and children that while about 60% of those not affected participated in community cultural events, sometimes or almost always, slightly higher proportions of those affected by residential schools reported. So just showing that, want and feeling and need to seek out re-engagement in culture. And not only were they more likely to seek it out, our research is showing how these aspects of cultural identity and cultural engagement is protective in relation to health and well-being. Just to give you some examples, this is an early study we did when we looked at the relationship between perceived discrimination and depressive symptoms. And we looked at it as a function of, here it says in-group affect, which is really just a fancy term for cultural pride. And we found that those with low levels of cultural pride were protected against the negative effects of perceived discrimination compared to those who had high levels of cultural pride. Sorry, people with high levels of cultural pride were protected. And likewise, we looked at the relationship between bullying and psychological distress in First Nations communities, and this is in youth. And we find that those who had strong feelings of belonging in their community were somewhat protected from psychological distress compared to those who had weak feelings of belonging. And just to give you an idea, this research we've been using in Canada to really advocate for the importance of culture and culture-based interventions for Indigenous people. There's not a lot of funding that goes towards these types of interventions and just community well-being approaches. And so that's something that we're working towards. Our research has also been very helpful in class action lawsuits that are seeking justice for those affected by these policies. And just to end on I wish I didn't need to keep doing the same research showing the long-term and intergenerational effects, but in Canada, at least, there's somewhat of an increase in the violence of denialism. There's some Canadians who continue to defend residential schools, still deny that children abuse suffered, or try to kind of minimize the impacts by noting that myth I mentioned earlier, that the nations has treated Indigenous people well. And so just have been calls in Canada, and I think around the world, this is potentially an issue for education about history, about the ongoing legacy of residential schools and the personal responsibility of non-Indigenous Canadians. This is a quote from this report saying, denialism is a uniquely non-Indigenous problem. It therefore requires non-Indigenous people to actively work towards to counter denialism and to create and implement strategies to do so. And just to end on some, these are some of my heroes in Canada: Dr. Pamela Palmater, Dr. Cindy Blackstock. She is a international children's advocate who led a huge class action lawsuit, human rights tribunal against the Canadian government, and pointing out the underfunding for child welfare services on reserve, despite the increased needs associated with Red 60 Scoop and residential schools. And they won. And so Canada was found guilty of racism. And this has resulted in billions going towards trying to start to rectify those gaps that continued all those years. And so that's it for me. Thank you so much. I, of course, didn't do this work on my own. So many people were helped, and please feel free to reach out to me. So I'll hand it over to Rachel.
Thanks, Amy. That was great.
Go ahead, Rachel.
Yeah, so you see my slides?
Yes, wonderful.
Thank you. I am so honored to have the opportunity to talk with you today. So I'm going to be building on a lot of what Dr. Bombay just talked about, and I'm going to shift the focus towards the United States and the federal Indian boarding schools, as well as some strengths-based constructs for shifting the narrative around Indigenous health. Before I begin, I wanted to say that I'm presenting this talk remotely from the unceded traditional and ancestral lands of the Coast Salish peoples, who are the original inhabitants of what is now known as Western Washington State. In order to go beyond lip service to reconciliation, I'd like to invite you to join me to take the time to learn about the original peoples of the lands that you currently inhabit, to learn about their culture, learn what they want for their people, and to participate in community events that are open to the public, but to do so while respecting sovereignty and autonomy at all times. It's really important to remember that Indigenous peoples are alive and thriving, and we're not remnants of the past. So I personally reside in 2 places on the traditional homelands of the Duwamish, the Samish, the Swinomish, the Stillaguamish, the Lummi, and the Tulalip. So this is just a general outline of what I'm going to be talking about over the next half hour or so. I'm going to start off with a little bit of background information, definitions, and things like that. And hopefully some of this is a review, but I understand this is an international audience, so there's probably going to be some that's new. But I always find that it's really best to be explicit and clear about who and what I'm talking about. I'm then going to shift to talk about some of my research into the physical health implications of the federal Indian boarding school system in the United States. And this is a similar system to that which Dr. Bombay was just talking about, but on the US side of the border. I'm then going to move on to talk about resilience, to talk about the benefits and limitations of that construct within Indigenous spaces. And then I'm going to shift to present a decolonized or indigenized potential alternative. So we'll just get started with that background information. So I'm going to use a couple different terms to refer to the First Peoples of what is currently called the United States. And I think that it's really helpful to define those terms or other terms that people may be used to hearing. So one of the most common terms that we see is American Indian and Alaskan Native, and this is the terminology that's utilized by the U.S. Office of Management and Budget. So it's therefore used for official federal data collection and documentation, including on population surveys like the U.S. Census. So on its own, American Indian refers to peoples indigenous to the lands covered by the lower 48 states, while Alaska Native comprises the indigenous peoples of Alaska. Native American is a more broad term than American Indian and Alaska Native. So in addition to the indigenous peoples of the lower 48 states in Alaska, it also includes Native Hawaiians, Chamorros, and Samoans. Indigenous and Native are more generalized terms that are often used to refer to the First Peoples, so they can be used, but Indian on its own is pejorative and it should be avoided. So this map comes from nativeland.ca, and it's a project that aims to document the traditional and contemporary territories of Indigenous populations around the world. It's a really great resource, and I encourage people to go check it out. So there's a lot to unpack in this map, but what I wanted to explicitly get across was that each tribal nation has its own unique geography, culture, history, religion, and language, and that they don't coincide with contemporary geographic boundaries. So the idea of referring to all of these peoples as a homogenous group is not only inaccurate, but when we're thinking about factors that impact health or health care, it could actually be really harmful. So each tribal nation or community has a specific name, while many have both a name that they're called by others as well as ones that they call themselves. So whenever possible, it's preferred to refer to Indigenous nations by their own names. It's important to recognize that within the United States, in addition to the Indigenous nations and peoples that have a political relationship with the US government, there are also state-recognized and unrecognized, as well as Latinx Indigenous peoples and Indigenous peoples from other lands that reside in the US today. So I want to make it really clear that in order to keep this presentation somewhat focused, I'm going to be talking specifically about populations that were impacted by federal policies. So most of the time I'll be talking about American Indians and Alaska Natives. That's where my expertise is at. But I do want to acknowledge that this population is not representative of the entirety of Indigenous peoples in the United States. So in addition to this terminology, I also want to clarify something that's often misunderstood, but which has profound implications for Indigenous health research and practice. So American Indian and Alaska Native is a socio-political, not a racial designation. This fact impacts well-being directly through avenues like policy, but also indirectly through things like research methods and government reporting. So there were millions of Indigenous peoples that inhabited North America prior to contact with Europeans. They had vibrant societies and systems of government that included diplomatic practices, justice, healthcare, and resource management. So in the US, the tribal sovereignty that's enjoyed by federally recognized American Indian and Alaska Native communities predates the formation of this country. This unique sovereign status is recognized by the federal government in the US Constitution through the Commerce Clause, which allows Congress to ratify treaties with tribal governments. So a basic understanding of this political context is really critical. American Indians and Alaska Natives share a complex, unique, and constitutionally established relationship with the United States government that ensures inherent rights that are not derived from race or ethnicity. So federal law and policy distinguish between Indigenous and non-Indigenous peoples. So fundamentally, American Indians and Alaska Natives are members of nations with sociopolitical identities, not simply racial minorities. So there's a lot more that I could say about this, and Amy touched on some of it, which I really appreciate. And about the role that inappropriate and inaccurate racialization has played in American Indian and Alaska Native opportunities for health. However, I'm going to keep it brief and just share this important kind of tip of the iceberg bit of information about one of the key contributors to health inequity for American Indians and Alaska Natives. So since the 15th century, the experience of peoples indigenous to what is currently the United States has been one of colonization. With the establishment of the US, the federal government explicitly sought the elimination of the land's Indigenous peoples through genocide, relocation, and assimilation. So policies and practices that perpetuate inequity have continued into the present. So given its temporal scope, colonialism is an ongoing structure of domination for American Indian and Alaska Native peoples, and this results in cumulative wounding across generations from both discrete and chronic traumas. And this makes it a significant determinant of health for American Indian and Alaska Native populations. So with that said, I'm going to shift now to talk about the federal Indian boarding schools, which represent just one of the many federal policies that have had a direct and devastating impact on American Indian and Alaska Native peoples. There's a large and growing body of research on the federal Indian boarding schools in the US, as well as on the residential schools in Canada. So with respect to time, I'm just going to talk about one small segment of that, which is some of the research that I did for my dissertation. And I'm not going to get into a ton of details of that study. I think Amy covered a lot of the findings really well. Ours mirrored a lot of what she talked about. But the findings are really important because they inform the second half of the presentation. So a key tool in the government's colonial toolkit was the Indian Federal Boarding School Program, which began in the United States in the 1870s. The program removed children forcefully from their families, and in addition to instruction in menial and gendered labor, it forced children to abandon their traditional language, religion, and clothing. There are reports of significant physical and sexual abuse and neglect suffered by attendees of the institutions. The system was developed with the explicit intention of assimilating and eradicating American Indians and Alaska Natives through forced cultural erasure and the disruption of family and community ties. So the overwhelming consensus is that the federal Indian boarding school era was devastating for Native nations, communities, families, and children. At the program's peak in the early 1900s, up to 25,000 Native youth per year were enrolled in more than 350 boarding schools in 29 states. The federal boarding school era largely ended in the United States in the 1930s, which is a little bit earlier than in Canada. However, states and religious organizations, and later some tribes, have continued to run boarding schools for American Indian and Alaska Native youth into the present. So I do want to make it really clear, though, that many of these contemporary boarding schools differ dramatically from earlier models by encouraging cultural engagement and supporting Indigenous students to thrive, using both traditional and Western educational models. So these modern contemporary schools are not what I'm talking about when I refer to boarding schools in the United States. So Dr. Bombay just provided a really great introduction to the residential schools in Canada. So I'm not going to get into too many of the similarities and differences here, but I'll just note that the Canadian residential schools were originally based off the US schools, but that they continued much longer, and that they were run by religious organizations. While in the United States, the schools were organized by the federal government, although many were then run by independent religious organizations. So this is a picture of Carlisle in Pennsylvania, which was one of the larger and more notorious boarding schools. So the study that I'm going to talk about today examined how different patterns of exposure to boarding schools, both personally and intergenerationally, impacted physical health for contemporary American Indian and Alaska Native peoples. So we did this by asking, how does a personal, family, and multi-generational history of boarding school attendance impact self-reported and objectively measured physical health? What are the early life and later life factors that influence the relationship between intergenerational American Indian boarding school attendance and respondent struggles with parenting as one of those pathways through which trauma can be transmitted? And how does engagement in traditional cultural activities impact the relationship between American Indian boarding school attendance and physical health within an urban American Indian and Alaska Native population? So this study was a secondary data analysis of research that was originally collected by Dr. Karina Walters, who's formerly at the University of Washington, is now at the National Institutes of Health, and it's managed by Dr. David Hugh, who's at the University of Washington. The data was collected as part of a comprehensive multi-site cross-sectional health survey of American Indian and Alaska Native peoples from 7 urban centers, and data collection occurred between October 2005 and November 2006. Potential participants were identified through a combination of targeted, partial network, and response-driven sampling techniques, and a response rate of 80.1% was achieved. So I don't have time to go into the analyses for each of these questions. They ended up being pretty complicated, but what we found when we contextualized our findings in relation to this multi-level historical trauma framework that I'm showing here on the screen, and that's important because it considers impacts of individuals, families, and communities, was that at the individual level, all participants in our study had some level of exposure to the boarding schools. And this was a lot greater in scope than that is anticipated. So in the United States, we don't have records, good records of boarding schools. They weren't kept intentionally. And so the narrative has been similar to Canada, that a lot of people were not impacted by the boarding schools. And our study shows that that is simply not the case. We also found that the type and magnitude of exposure matters, with trauma appearing to compound, similar to Amy's findings, across multiple generations of exposure. And we found that grandparental attendance appeared to play a really large role in the physical health of their grandchildren. At the family level, our findings suggested that both early life and later life experiences, so those ACEs that Amy was talking about, as well as experiences as an adult, mediated the relationship between having that intergenerational family history of boarding school attendance and one's own confidence or experience in raising your children. We also found that despite the disruptive nature of boarding school policies, people with some family history of boarding school exposure were able to maintain strong networks of social support and self-esteem, and they reported confidence in their ability to raise their own children. So this was really interesting because parenting is often indicated as a primary mechanism for the transmission of trauma across generations. And then finally, at the community level, we found that people with some intergenerational exposure to boarding schools appeared to be actively engaging heavily in traditional activities. Again, this mirrors Amy's findings, despite or maybe because of that exposure, and that this engagement was associated with better physical health. So collectively, what these findings show is that intergenerational boarding school attendance does have impacts for Native individuals, families, and communities. However, while these findings demonstrate that a family history of boarding school exposure has negative implications for physical health, they also show that it's possible to engage in activities that interrupt that relationship. So, for example, people in this study who had a family or a caregiver exposure to boarding schools exhibited really remarkable rates of social support, particularly those who also self-reported struggling as a parent, indicating that participants may be actively seeking to reduce the burden on themselves and improve outcomes for their children. People in this study also demonstrated agency in addressing the transmission of trauma through engaging in traditional cultural activities at higher rates, and that this had positive impacts on their physical health. So overall, these findings show that a family history of boarding school exposure is not deterministic. Over the past 30 years, American Indian and Alaska Native people have been talking about and engaging with the concept of historical trauma and the theoretical pathways that through which traumas of the past continue to impact the health and well-being of Indigenous peoples today. So it's not unlikely that participants in this study are demonstrating both survivance and resilience, and I'm going to talk about these in just a minute, by engaging with these narratives of the past and using them to work towards healthier futures for both themselves and future generations. So that's what I'm going to talk about for the rest of the presentation. So as I just said, in my dissertation research, I did find that there were the expected poor health outcomes that seemed to compound with the number of generations of exposure to the boarding schools. But I also kept finding something that the literature hadn't necessarily led me to expect, and that was that there wasn't this simple relationship between experiences of trauma for Indigenous peoples and health. Instead, and time again, I was seeing that people in the data set I was working with appeared to be actively engaging with that family history of trauma, and that in many instances, people appeared to be leaning into many of the strengths of their families or communities in order to do so. So when I say strength in this context, what I'm talking about is things like relationships, spirituality, and culture. So this was important for a number of reasons. First, it was contrary to the overwhelming narrative that I had been taught in my public health training, which was essentially that trauma led to poor health, and that this was particularly true for Native peoples. So the literature, fortunately, at this point has moved on from attributing poor health to strictly biological variables, and this is really great, obviously, and had evolved to include structural inequity and discrimination as contributors to American Indian and Alaska Native poor health outcomes. However, the emphasis remained on disease and disparity. So this is referred to as a deficit-based narrative or narrative of pathology, meaning that the emphasis is on that disease. So these deficit-based narratives tend to emphasize determinism, either biological or social, and focus on ways to reduce the burden of disease, but they rarely include anything about the other side of that equation. So what makes people healthy? So instead, what the data that I was seeing was reflecting was that trauma did impact health, but that it was not deterministic, and that there were actions and practices that people were taking that could change that relationship between intergenerational trauma in their own lives and for the lives of their children. So this is not to downplay the very real fact that structural factors do, of course, impact health, but simply that that's only part of the story. So that was the first thing. The second part of this narrative of pathology that was really ground into me as a health sciences student was that there are populations that are inherently less healthy due to things like social determinants, and that as a health researcher, it's pretty safe to assume that people who are identified as being members of these populations are almost inherently at higher risk for poor health in various ways. So when I stopped, though, and I took a step back from my classes and my readings and my conceptual models, and I looked at my family and my community and my social networks, that was not at all what I saw. Instead, I saw people who experienced poor health. Of course, everyone does. But that poor health was not what defined us. So instead, what really stood out to me was the strength of particularly intergenerational relationships and the rich cultural practices that were intimately tied to things like joy and identity and spirituality and food and connection and humor, all of these things that make us human. And all of these occurred within the context of history, and particularly histories of colonization and contact. And, people always talk about these things. These stories of history are really frequently shared. But they're also shared alongside stories of strength and mischief and traditional knowledge. So research that incorporates these other important elements of humanity are often referred to as strengths-based or desire-based, as scholar Eve Tuck says. So strength or desire-based research is growing across health disciplines. And the most common strengths-based framing that is used is resilience. So resilience is a term I'm sure most of us are familiar with. So while it first developed in psychology in the 1970s, it's really spread into the public and popular vernacular, and it's used these days in relation to just about everything. But despite its broad usage, or perhaps because of that, there isn't a single agreed upon definition for resilience. However, it's generally understood to be some sort of positive adaptation in the context of adversity. So in 2016, a paper came out by Auburn, Gott, and Hore, which published an integrative review that identified 5 key elements that are shared by most resilience research. So I think that these are helpful for us to kind of understand what the focus of resilience is. So they found that most resilience research had an emphasis on rising above to overcome adversity, that adaptation and adjustment was the expected kind of meaningful change following exposure to adversity. The concept of ordinary magic, which was introduced by Anne Maston in 2001, came up a lot. And that's the idea that resilience is common rather than rare, and that it occurs most often through ordinary rather than extraordinary means. The idea that good mental health can be a proxy for resilience. And finally, the idea that resilience represents the ability to, quote, bounce back. That term is used a lot, from adversity without breaking. So resilience has been adopted within Indigenous health research, and its application mirrors a lot of those patterns that we see in conventional resilience research. When applied by Indigenous scholars or those with longstanding relationships with Indigenous peoples, however, we do see unique patterns that emerge in context and focus that differentiate Indigenous resilience from mainstream resilience models. So, for example, some note that Indigenous resilience is typified by cultural and collective persistence and knowledge. And many agree that resilience derives from original instructions or creation stories. Others point to oral histories, and there can be some overlap between those, particularly learning how one's ancestors overcame adversity. And land-based knowledge is often used as a guide for contemporary resilience. And this is particularly in relation to like environmental resilience or resilience for environmental change. So the importance of reciprocity and relationships are frequent themes, as is spirituality. And most agree that the outcome of Indigenous resilience is more than just bouncing back to a pre-adversity state. And many then emphasize community and culture. So there are a lot of different degrees of focus in Indigenous resilience, but most Indigenous resilience models are united around identifying colonialism as a primary contributor to chronic adversity and emphasizing the importance of traditional knowledge and cultural practices, including their transmission through narrative, as sources of resilience. However, there remains pretty significant Indigenous discontent with the concept of resilience. So when I was a graduate student in North Carolina, I was studying the impacts of historical and intergenerational trauma on contemporary health outcomes, and I gave a public talk to an audience that consisted primarily of urban minoritized peoples. Following the talk, an elder local American Indian woman who was both a friend and a mentor came up to me to discuss an alternative narrative, one in which ongoing Indigenous presence rather than systemic poor health was the emphasis. And this persistence, she was really careful to underscore, was entirely separate from resilience. So what she told me and what I've heard many, many times since then is, I'm tired of being resilient. So resilience terminology is regularly employed in relation to Indigenous populations around the globe as an explanation for the continued presence of peoples despite recurrent and devastating interruptions to ways of life. So in these settings, it's frequently presented as the only viable alternative to continued marginalization and poor health. So as a concept, though, resilience can be reductive. It depends on these experiences of adversity and minimizing the complexity of human experience before and after adverse events. It threatens to diminish the agency of impacted peoples, particularly Indigenous peoples, for whom persistent presence may be more powerful than reactive resilience. So Beyond this, conventional resilience inadequately acknowledges the impacts of perpetual structural violence on the lifeways of Indigenous peoples. And there's a lot of different facets of Indigenous research, of resilience research, and some of it does a better job of this than others. So despite the regular use of the concept of resilience by Indigenous communities and scholars, there is increasing discomfort with representing and studying Indigenous strengths-based conceptions or perceptions of well-being with resilience and other frameworks of health that are developed outside of Indigenous epistemologies. So part of this discontent derives from the idea that resilience, instead of being this universal concept that we often think of it as, is actually culture-bound and rooted in Eurocentric and neoliberal discourse that emphasizes individuality, or this idea of overcoming the odds. So in accordance with this way of thinking, individuals and populations are often defined as vulnerable in accordance with mainstream cultural norms and expectations. And this label is conferred without really considering the structural roots of that vulnerability. So those who then continue to survive within these systems that maintain subjugation are labeled resilient for surviving those very systems. So for many Indigenous populations around the globe who have experienced colonization, the concept of resilience has become so encompassing that resilient indigeneity is often considered an embodied trait. So successful colonial agendas perpetuate social hierarchies that systematically disenfranchise segments of the population. That's how colonialism works. And this results in long histories of structural vulnerability. So within resilience frameworks, the idealized response to adversity that arises from this vulnerability is adaptation rather than resistance. And within the context of global colonial agendas, this adaptation equates to these processes of acculturation and assimilation that we often see in settler colonial policies like the boarding schools. So these pressures require vulnerable peoples to continually adapt to foreign systems or foreign conditions. And this prevents equilibrium and it prevents the ability for resistance. So we can think of resilience then as it can be perceived as this adaptive behavior of vulnerable populations that ultimately impedes their ability to enact structural change. So for many colonized populations, resilience could equate to successfully treading water. So you don't drown, but you're too exhausted to get out of the water. Common resilience patterns that downplay structural contributors to vulnerability instead emphasize individual or occasionally community responses, adaptations, mitigations, and recovery from adversity. And they prioritize survival and coping rather than agency. So when we shift the onus for adaptation onto vulnerable populations, we effectively absolve the state of responsibility for structural factors that perpetuate risk and systematically harm some groups of people over others. So finally, reductive resilience frameworks downplay the impacts of perpetual colonialism in everyday life. They omit the reality that for settler colonial societies, there is not a post-colonial period through which transformation and sustainable healing can occur. So significant work has been done globally to tailor resilience models and frameworks to address the specific nuances of Indigenous health. And as a global system, though we maintain however, mainstream science remains defined by Eurocentric and colonial structures, and this means that any efforts taken to employ resilience towards improving health equity and well-being for Indigenous peoples must occur within those systems from which inequity stems. So in relation to health research, then we look at decolonization, and decolonization processes include divestment from systems that normalize and prioritize Eurocentric approaches to knowledge creation over Indigenous approaches. So in addition to shifting the power in research, decolonized research methods are those that are rooted in Indigenous knowledge, proceed according to Indigenous timelines, and conclude with the realization of Indigenous objectives. Decolonized approaches to resilience must emphasize continued presence, buttressed by Indigenous cultural practices, ways of knowing, and relationships that persist proactively despite adversity, not reactively in response to it. So I don't think that it's enough to simply refurbish resilience for general application to Indigenous communities. Instead, I think that the trauma resilience dichotomy must be fundamentally transcended through strengths-based approaches to Indigenous well-being that emerge from Indigenous ways of knowing and living in the world. So the statement, "We are still here," is one that's frequently heard in North American Indigenous spaces, and the sentiment applies globally to contemporary Indigenous populations. At the core of this statement lies a reality that Indigenous past, present, and future is that continued presence is the result of deeply held practices, beliefs, and relational systems that have enabled Indigenous peoples to navigate a changing world that is impacted by colonialism, but is not confined to settler colonial parameters. So if resilience isn't quite the right terminology, what is? And I think that the answer to that comes from Indigenous literature in the form of survivance. So survivance is a term that derives from Indigenous ways of knowing, being, and moving in the world. It encompasses Indigenous experiences, inclusive of both trials and successes, as a way of understanding where we are now and where we may go. Survivance was developed by Anishinaabe literary scholar Gerald Visner in 1994. It's a combination of the words survival and resistance, and the term represents continuation through stories and active presence. So integral to the concept of survivance is this interruption of what Visner calls manifest manners. And those are the static or inaccurate stereotypes of Indigenous peoples that are often recalled by resiliency narratives. So in resiliency narratives, there's that emphasis on bouncing back to the way you were before. And for Indigenous peoples, that idealized before is often a romanticized or stereotypical model of indigeneity. So survivance, on the other hand, is, as Visner says, an undeniable trace of presence over absence, nihility, and victimry. So essentially actively discarding that victim label. So the term was originally applied within literary domains, but the concept of survivance almost immediately gained purchase in adjacent disciplines like visual media and material culture and education. And this is where I ran across it. So when I began to look at the health literature, I wasn't seeing it frequently. I did find it occasionally, but it was used essentially as a synonym for resilience. So when I started my postdoctoral fellowship, my mentor, Dr. Joseph Gahn, and I started to talk about the potential for survivance to be valuable as a decolonized concept in Indigenous health spaces as something beyond resilience. So in order to do that, we needed to first get a comprehensive view of how it was being used. So in 2022, we performed a scoping review of survivance within the health literature. I'm not going to go into all the details of the methods or the frequency analyses. I just want to focus on some of the results of the content analyses. Because that tells us more about how scholars are actually using survivance in relation to Indigenous well-being. So there were 5 key themes that pertain to the adoption of the concept of survivance that were identifiable across papers, and you can see them here outlined in red on our conceptual map. So they were narrative, temporality, community, decolonization, and sovereignty. So essentially what this tells us is that primarily Indigenous scholars are emphasizing the role of sovereignty and agency, particularly in relation to communities, as well as the way that we talk about our history and our future, and that all of these ideas are essential to understanding how American Indians have continued to survive and thrive, and how we may continue to do so into the future. So we continue this work at last year's Native American and Indigenous Studies Conference in Toronto, where we convened a roundtable comprised of Indigenous scholars focused on health, so epidemiology, human biology, and psychology, as well as Indigenous studies and history. And these are the panelists here. And we came together to talk about the potential utility of survivance in health spaces. So through the roundtable, as well as really extensive and fantastic engagement with the audience, we learned that health survivance was perceived by participants as a means of divesting from cycles of structurally rooted and allocated risk, and that there was enthusiasm for the concept as a decolonized and strengths-based approach to Indigenous health. Some attendees in the audience cautioned, however, that empirical health constructs could be subverted in harmful ways, and they cited histories of abuse, dehumanization, and neglect by health researchers. The main concern was that measures of health survivance could be inappropriately used to label some communities as having high survivance and others as having low survivance, which would unintentionally contribute to those narratives of pathology that we were attempting to avoid. So that was really, really great feedback to get. And then this past spring, this same group met again at NISA in Buda, Norway, to continue the conversation. And this time we focused on different facets of survivance in relation to well-being, including traditional language roots and disease etiology through the lens of epidemiology, survivance as an action from the perspective of Indigenous studies, the role of narrative in survivance well-being through psychology, and the influence of power in survivance opportunities, health opportunities as perceived through anthropology. In the spring of 2023, that same panel met with Gerald Visner for 2 days at Harvard University with the intention of further grounding this conceptualization of health survivance. So the conversation revealed the terms links to individual and community engagement with behavioral health and holistic well-being, and it was motivated by experiences of structural adversity tied to historic and ongoing settler colonialism. So this was despite the fact that Visner developed the term within his home discipline of literature. So specifically, Professor Visner noted that the idea for survivance began to come to him through his work as a social worker with Indigenous youth and unhoused populations, as well as his experiences as a staff member in a psychiatric hospital. So the end of our final conversation, Visner concluded that survivance could be considered, quote, the stages of health. It's a long stage story. So collectively, through these activities, these activities illuminated health survivance's theoretical and interdisciplinary roots as a strengths-based construct that emerged from Indigenous ways of being and observations of the world. Its present usage as a decolonized but largely undefined alternative to resilience in Indigenous health spaces, and its promise for future application in the health sciences. So based on these efforts, as well as 2 years of conversation and consultation with interdisciplinary health scholars, we've developed an idea for how survivance functions in health spaces. So we propose that health survivance to be proactive, strengths-based, decolonial construct that balances persistent survival with intentional resistance to the status quo, functioning at the level of community and culture to fundamentally shift the narrative from historical marginalization to ongoing thriving presence. So health survivance celebrates that we are still here due to the irrefutable strength of our cultures and our communities, which enable adaptation on Indigenous terms to perpetually and rapidly changing environments. So within health survivance, communal well-being is achieved through community strength and identity, enacted via sovereignty, agency, and empowerment. The construct of health survivance illuminates the complex and interrelated factors that have enabled American Indians and Alaska Natives to survive and thrive across time, emphasizing factors like relationality, humor, and spirituality. So the nuances of health survivance are unique to each community because they're shaped by history, culture, tradition, politics, and relationships. There's not one model or one definition. So I started off by talking about resilience and how this project was motivated by some of the incongruities of resilience for issues of Indigenous health. So because of this, I think that it's really helpful to compare and contrast health survivance and resilience. And I think that we can do this through 4 key differences. So first, health survivance promotes persistence and thriving presence through resistance and contestation of the status quo by Indigenous peoples situated within the structure of settler colonialism, and enacted via both overt and subtle actions. So this resistance to the status quo differentiates health survivance from resilience in that it enables the transcending of those systemic barriers that perpetuate health inequity, rather than adjustment within the confines of an unjust system. Second, health survivance incorporates a temporal arc that's inclusive of the past, so ancestral experiences, the present of the living community, and the future or subsequent generations. So this arc integrates traditional knowledge and oral histories alongside contemporary socio-political and environmental realities to foster a sustainable and thriving future for upcoming generations. It's really important to note that the envisioned future is not a return to a romanticized or a pre-colonial state, so those manifest manners that Visner talks about, but rather the generation of something new, reflecting the complexity of modern indigeneity. So conventional resilience, particularly that which is enacted primarily in response to acute trauma or adversity and is aligned with mainstream conceptions of time as linear, is primarily concerned with individual adaptation in the present. Third, health survivance is inherently focused on community and cultural persistence. So within health survivance and in keeping with many Indigenous practices, individuals exist as part of an interrelated whole comprised of relationships with the people and other than human relatives around us. So because of this, well-being is collective and community persistence is emphasized over individual survival. So this is in contrast to resilience, where the primary emphasis remains largely on the individual in the present or near future. And finally, health survivance fundamentally and explicitly refuses identities of victimization and vulnerability. So health survivance is self-determined by Indigenous communities. It embraces collective knowledge, actions, and beliefs to uphold pride and tenacity in Indigenous identity. Health survivance is inclusive of systemic chronic adversity derived from ongoing settler colonialism and associated historical trauma, as well as Indigenous strengths. So because of this, health survivance includes acknowledgement of historical challenges and their role in contemporary lived realities, but resists being dogmatically defined by them through identities of victimhood and perpetuity. So this brings me back to my original discontent with narratives of pathology that I talked about earlier. So Visner refers to this as a reframing of Indigenous identities outside of the erasure and victimhood that occurs through colonialism. So because of this, rather than being a reaction to vulnerability or a state of victimhood, health survivance is an active resistance paired with collective recognition of what has been, what is, and what can be. So resilience often, but not always, incorporates a deep and enduring consciousness of adversity and trauma in relation to the identity and mentality of those who have been impacted and are therefore eligible to be resilient. That is what I have for today. And I'm really grateful for the intellectual contributions of the folks on the screen. Many of the ideas on which this presentation was based have resulted from years of collaborations and conversations with other Indigenous scholars and communities. So I do want to acknowledge broadly that I'm a product of my family and community, both natal and academic. So thank you. Oh, I think you're muted.
Hi, Dr. Daniela, you're muted right now. Your microphone is on mute.
See, I was excited too. Okay, so I said to start, thank you, to start the dialogue among the three of us first before inviting the audience. Let me acknowledge formally that the ICMGLT is headquarters where the Lenape lived before and during colonization of the Americas. We recognize these indigenous people of Manhattan, their displacement, dispossession, and continued presence. Sorry, and continued presence. And I'm going to do something rather untraditional for me, which is we really have to have a very serious conversation about the concepts, because it's not the first time we've been thinking about it. Indeed, what you remember from my book, 1998, we have had some discussions already then. And I both challenge you and invite you and extend my heart and mind and soul to share with you my thoughts about these issues. Because there have been so many, being 84, it gives you a lot of time to think. So that's number one, and I'm very excited about the possibilities. And in the same vein, I would like to suggest that, Amy, in your excitement about genetics, epigenetics, etc., and decision to go that route, I suggest humbly but profoundly that you also really work on adapting the Danieli inventory. And I'll work with you 100%, the same with you, Rachel. The Danieli inventory and the Danieli thinking, for example, about identity healing rather than like this one thing or another thing or another thing. With all due respect, really deep respect to the thoughtfulness of what you have shared with us, really both in terms of very systematic research. Your data is exemplary, but also really comprehensive thoughtfulness. I'm so excited. We are very, very, very fortunate. I hope all the audience knows how fortunate all of you are, as I feel, for having this amazing conversation. In addition to also listening and reviewing our past webinars on the same topic, you will see how many ways there are to try to find language, to just try to find the words to describe what happened and the consequences to it. So go ahead if you have some more. I know you converse all the time, but if you want to still have some discussion among the three of us now, that's okay. Otherwise, we have so many questions. Wow, you're breaking the mode here. Amy, Rachel, unmute. Would you like to say anything to each other or me first, and then we open the floor?
I just really enjoyed your talk, Rachel. I'm okay with questions, but Rachel, go ahead, Rachel, if you.
Yeah, no, I agree. I mean, a lot of my dissertation work was based off of what you were publishing previously and have continued to publish. So it's always really wonderful to share space with you and be in conversation.
But I'm not just talking about what I was publishing in the past. I'm talking about when I was 70, I became a researcher on top of being a clinician and an author, and established the measure for multi-generational legacies of trauma that we have already, we standardized and did comparative work across the world and with many different populations. So, so I'm not just talking my old thinking. I was challenged to create a measure after all these years. And so there is hope you can become new things, even at age 70. So, so let's open to the Mary. I think you just wrote something. Yeah, Mary Fabry, who is the chair of our, the co-chair of our Indigenous Working Group, says, Amy and Rachel, excellent presentations. Amy, the concept of survivance, it's actually also Rachel, is so important and interesting. Exactly. Her mind is also very excitable about these things. So we have great appreciation. So, thank you, Mary. Would you like to say anything? Or is that sufficient? Okay, if you do, you let me know as usual. Let me attend to the questions. All of you can look at the questions. Larry Holman always asks big questions. So I will just read all the questions and you choose. Okay, so Larry says, what role does the international oligarchy? You probably also mean patriarchy, but at any rate, oligarchy, with its increasing consolidation of power. Yes, very threatening today. So what does the role play in creating victims of all species, races, and genders everywhere in the world? Can this be understood better by seeing it as an exploitation according to class, regardless of other factors usually used to separate people from each other? Larry, may I jump and say, yes, these are two important dimensions. I will be leery of reducing any global explanation to one or two dimensions. But let me just read the rest of them, and you can also, please, Rachel and Amy, respond to that. We always have an anonymous attendee who asks very important questions. So, could it be that the quote Stockholm syndrome is an adaptation that may be at least temporarily healthy and demonstration of resilience? Within the situation, yes. If it stays with you forever, no. Okay, Larry, again, the question about Stockholm syndrome is mine. Oh, so you're not anonymous. Okay. And another one, Larry, come on. Is it useful for the victim to focus too much on their own victimhood? Okay, do you want to pick on any of these or we continue? Go ahead.
I guess I would just speak to the last question. And I think this is why survivance is so great, is I feel like showing the roots of whatever our current, whether it's personal, family, community, population level, I think finding, not, instead of blaming ourselves, we understanding that history and what has contributed helps. But then at the same time, and this is, I think, why survivance is great, to help balance that with the continued intergenerational strengths that go along with that. So I think it needs to be balanced. I think it's important to recognize that, these things have been done to me and contributed to these problems, while at the same time balancing that with recognition of strengths.
Rachel?
Yeah, I
you want
think that
to take on any of this question?
yeah, sure. I mean, I think I can speak to the first question a bit as well, and I agree with your response to it. I think that it's really important to understand how power across the world and across time has impacted hierarchies and systems of opportunity for people. And I think that functions, as Larry mentions, in relation to class. It also functions in relation to these artificial, racial designations. I mean, there's a million ways in which these play out as social creatures. We create these boxes that we put people into that enable opportunity. And so I agree that, limiting that to one type, so class or race, can be limiting, but I think that you have to look at the specific circumstances and priorities of different cultures and communities, because they will all impact people in different ways in different places and times.
Thank you. Let's see. We have several. I promised you that this will be worldwide. You have Nigeria, you have Rwanda, you have on and on, as I promised. So, but I see that some of the participants are actually, for example, Terhemba is from Nigeria. Are you still here? Rabbi, you can help me. Is Terhemba still here?
Yep.
Does Terhemba want to share your impression from the Nigerian perspective? Let's see.
Looks like he's muted.
Terhemba, would you unmute, please? Okay, so let's continue. What about Kendall Smith? Would you like to share with us your response? Kendall is Native American Connections, which operates Phoenix Indian School Visitor Centers, which is an Indian boarding school that operated from 1890 to 1989. My God, so long. God, okay, this is at least 3 generations. Kendall, would you like to
Yes.
share? Here she is. Hi. Join
Hello.
us. Hi. Please
I'm a
go.
grant writer for Native American Connections, which is a nonprofit in Phoenix. And about 4 years ago, we undertook the renovation of the Phoenix Indian School's former band building, which was also prior to that the primary school, in partnership with the Phoenix Indian Center. And currently it serves as a community gathering place for meetings, important gatherings. There's a commercial kitchen and a small gallery within it of memorabilia. And it's interesting because the alumni group is both the traumatized population of which you speak, and then we have graduates up through 1989, students, when it was purely a high school then, whose experiences were much more positive. So there's an interesting blend in the people who come to visit and pay their respects. We're putting together what we hope will be a videography, oral recording, documentation of the authentic stories of all of the former students. It's underway. It's a large process.
Absolutely.
But thank you. It's been an
Can
informative
you,
conversation.
can you just tell us very briefly how the visitors respond? Do you look at that?
Yes. Many of the relatives of the former students are very moved. We offer a separate space for reflection. Some are overcome by the stories from their grandparents. And there's also the students whose experiences were much more positive and in a contemporary fashion, traditional high school experiences. So it's a mix. Interesting.
Yeah, makes sense. Thank you. Elena Celestewa, are you here? Elena operates the Phoenix Indian School Visitor Center in Phoenix, Arizona. Is Elena still here, Robbie?
No, I don't see her name up here. Sorry.
Oh, God. What about Winona Single? She's a professor at Michigan State University College of Law and director of the Indigenous Law and Policy Center. Her mother's parents both attended Holy Childhood School of Jesus Indian Boarding School in Michigan, and she and her siblings were removed from her parents' home by Catholic Social Services and placed in foster care. Is she still here, Robbie?
No, she is not. Sorry.
Okay, but at least we are acknowledging that she was with us. This is very interesting that we had people who are responsible to history preservation joining our presentation, isn't it? So, Rachel, Amy, any last word? Any impression you'd like to leave everyone with or to ask? Take your time.
I would just say that, go for it, Amy.
No, you go ahead.
I was just going to say, I really appreciate the opportunity to talk and converse in these shared spaces. So often what we do in academia is really siloed, or kind of in Indigenous research spaces, we're talking with other Indigenous researchers researchers, which is wonderful. But we don't often have the opportunity to speak or to converse in global contexts. So this has been fantastic.
Yeah, we have to continue this because this is an extremely enriching conversation forward. Even to just learn each other's, the languages we use to talk about what we are talking about. Amazing, isn't it? Amy, please, the last word is yours.
I just wanted to thank you and you know, echo what Rachel said, and thank you so much. And I encourage everybody to, you know, look at the Indigenous groups wherever they are and try and be a good ally.
And just so I don't forget, there's one person who asked if she can receive your PowerPoints, Amy. Is that possible?
Yeah, of course. Yep.
Okay. And now it's important that the webinar recording will be available later today. So everyone who wants to tend to it, go ahead. And I just look forward to continuing this. Take care.
Thank you. Bye.
Bye. Thank you, everyone. Let me, before we leave, no, I forgot to say that next Wednesday, we have the upcoming webinar. You will receive the flyer later on today. And that webinar is extremely important. Is, of course, Buakaiman, the spirit of freedom and liberation in the arts and culture. And it is done by our Haiti working group. Please register and disseminate it as widely as possible, and let's continue our learning. Thank you, everyone. A big hug to all of you from New York. Bye.
Thank you.